Really, I'm very pleased and honored to be to participate in this very good meeting as usual, and this your meeting. I want also to thank all the redaction committee for this new guidelines for 2026. I want also to thank Dr. Hassanin for this very kind experience and this very good collaboration between us. So the topic of my presentation today is about the macrovascular disease, if it's a risk for fasting in patients with diabetes. So we know that the most of Muslim patients with diabetes and cardiovascular disease insist to fast in Ramadan. And always I see the same thing, that we need evidence and more studies. So here, before explaining and giving the new guidelines, just here to define the macrovascular disease. We know that the macrovascular disease could be a complication for diabetes, type 1 or type 2 diabetes. It could be coronary artery disease. It could be a cerebrovascular disease. It could be the peripheral artery disease. So here we know that this macrovascular complication is situated on an intersection between two things. The first thing is the stress. We know that during Ramadan, there is an increasing of stress because of dehydration, because of the raising of the risk of thrombosis, because of the increase of blood viscosity. But in the same thing, we know that these patients with cardiovascular disease that have already cardiovascular disease require complex therapeutic regimen. And in the majority of cases, these patients are treated by a lot of medication, statin, antiplatelet, insulin, and all this should be adjusted during Ramadan and requires a precise timing to avoid complication and adverse events. So here we know that we have already our guidelines from 2021 and that categorize patients with cardiovascular disease. But during this 4 or 5 last years, there are a lot of publication and especially a real world data that we can have and that we can explore and have a lot of conclusion from this real world data. And I'm talking about our DAR global survey between 2020 and 2022. It's about 12,000 persons who were investigated during a real world study. And we know that the person with cardiovascular disease or macrovascular disease, the group included about 1,500. So for this reason, during the two last years, we did a lot of investigation and a lot of investigation to see the characteristics of these patients who are fasting, who want to fast during Ramadan. And the good news, we have already published this paper a few weeks ago with Dr. Hassani, me, and a lot of colleagues, and to see the impact of macrovascular disease in people with type 2 diabetes on Ramadan fasting. And the study design, as I told now, that it's about an observational real-world cohort study. It included patients with type 2 diabetes who provided data pre and post Ramadan, and we have collected data from 7 global regions, and it was a big data, and I want to thank everyone and who participated in this study. So here in this group, we have about 12,000, and we have focused on this group with the macrovascular disease that was about 1,500. So the key study objective is, one, to compare the behaviors, to see the characteristics of this person who have cardiovascular disease, to compare them with the non-cardiovascular diabetic patients, Then to assess the safety, because it's very important to see and to evaluate the risk of hypoglycemia, hyperglycemia, hospitalization. And also, and this is also, it's very important, is to identify the gaps. The gaps that mean the reach of Ramadan-specific education and self-monitoring practices in this high risk group. So for the table 1, or the baseline characteristics, so here you can see that the person or the people who had cardiovascular disease are more aged, the duration of diabetes is more high, they are not well controlled with an A1C bigger than the control group, and then we have high systolic blood pressure, and you can see here for the p-value, all these p-value are very significant. So we can tell that there is a difference between this group for their baseline characteristics and the group without cardiovascular disease. So then when we see the major cardiovascular risk to do this macrovascular complication, I'm talking about the hypertension and dyslipidemia, and we can see that we have more, we can tell that almost the double of patients who have cardiovascular disease have already hypertension. The same thing for dyslipidemia, and hypertension and dyslipidemia are very frequent in the group with cardiovascular disease. Then the clinical profile for these patients with macrovascular disease, they have longer duration, higher A1C, and for medication, we have more patients that are that were using the insulin. And you know, because they have already a duration that is high of diabetes, and we know that are not well controlled, and the majority of cases we use insulin in these cases. In the same thing, there are less metformin uses in the group with cardiovascular disease. So then when we compare this person with this cardiovascular disease with the control group, we can see that about 70% with macrovascular disease group wanted to fast, and the P was significant, but not a lot significance. And the duration of the fasting was, we can see that it's almost similar between cardiovascular disease patients and without cardiovascular disease. So then, and this was a very interesting result, it's about the adjusted odds ratio for hypoglycemia. So here we have found that the person who have hypoglycemia, they break the fasting in 25%, and this after adjusting for age, duration, insulin use, A1C, and A1C. So what it does mean? It does mean that there is an independent increasing the odds of risk of hypoglycemia in the group with cardiovascular disease comparing to the group without cardiovascular disease, that obliged the person to break the fast. And this was a good result, statistical good result after doing the adjustment for the other independent variables. So then for hyperglycemia, really in this study, we didn't find any difference in hyperglycemia. Same thing for hospitalization. Then we found that there is an education gap. It's about more than 40% of these people with cardiovascular disease that fasted without structured medical guidance and without structured education, and it's really a negative result for our practice. So for this first paper that really we used we used all the data from DAR survey, and then we published this paper, the summary of risks, that the duration of the person who have cardiovascular disease and who fast is bigger. There are a risk of hypoglycemia, and it's the main cause that force person to stop fasting more frequently. And as conclusion, the person with cardiovascular disease or cardiovascular disease is a marker of fragility in fasting, necessitating stricter stopping rules. And was very important. Then from the same data and the same survey, so here it's about hypertension and Ramadan. And I'm sure that now if we repeat the investigation, we will have more patients with hypertension because, as you know, we decrease the cutoff for the definition of hypertension according to the new guidelines. So here in this data survey, we have about 3,000 hypertensive patients that were compared to 7,700 normotensive patients. And what we found that this is what we call the red zone. The red zone is uncontrolled hypertension with high A1C. And here it was about 40% person with high systolic blood pressure with an A1C more than 90%. And could be a main risk to increase the complication from microvascular and macrovascular diseases. Then, recently there is one study that we have done with Monastir Research Group, a group in Tunisia, about the blood pressure variability, and here to see the impact of Ramadan on blood pressure variability, and if this could have some impact from endothelial dysfunction. And in this study, we look to the blood pressure variability, but we measure in the same time before, during, and after Ramadan, we measure the endothelial function using the EndoPath. So here the key results of this study that now it's under press. So the key results that Ramadan fasting significantly increases the blood pressure variability. But Ramadan does not worsen endothelial function in healthy subjects, apart from in one case, when we have patients with impaired function of or endothelial function in the baseline impaired endothelial function. During Ramadan, this person will have less deeper profile. So this person will lose the nocturnal blood pressure drop, and this could be not good, especially for person at high cardiovascular risk. So after I just really choose this studies because it's already published, and it's new data about the blood pressure variability. Now we can move to the recommendation, to the new guidelines that will be published very soon, the 2026 diabetes and Ramadan practical guidelines. And the next week, I think by 9 December, we will have the new ADA guidelines, and you will see a part of these guidelines that is in the diabetes care paper. And of course, we want to thank all the participants and all the redaction committee. So here, first thing, the acute coronary syndrome. So really, when we reviewed the studies and the literature, we found some conflicting finding on incidence of acute coronary syndrome. What we found that really there is no significant association of coronary syndrome between a person who fasts or who does not fast, but during Ramadan. According, for example, the new events during Ramadan, or person with history of coronary syndrome during Ramadan, there is no an increase of the rate of coronary syndrome, apart from one study. It was also in Tunisia that was demonstrated or described that there is an increase of acute coronary syndrome during Ramadan. So here, in these guidelines, what we can tell that the major adverse cardiac event, the MACE, were increased in patients who fasted within 90 days of percutaneous coronary interventions. And the risk was highest for those with the syntax score more than 22 or who underwent complex procedure. So here we should keep attention. There is a caution for person who did the event during the 19 days before Ramadan. So for this person, we should really contraindicate the fasting of Ramadan. Then for stable person, here we can discuss with the person and assess for the new, if there is complication or other risks. So this was the crucial caution is this the history of a new event during the 3 months before Ramadan fasting. Then for the heart failure, in general, the majority of cases they didn't find that there is an increase in hospitalization for heart failure among diabetic patients during Ramadan. But this could be significant in some specific subgroup, especially the patients who have kidney failure with eGFR less than 50, the person who had the history of arterial fibrillation, the person with higher NIHA score, and the person with the history of revascularization. So here we can have increasing of the events during Ramadan. So, and another study, it was a prospective study in heart failure with preserved ejection fraction. And these patients showed an improvement in NIHA class, diastolic function, BNP, and HDL level with no increase in MACE. But this was when they follow the education and follow the advice of their doctors. So for the arrhythmia and cerebrovascular risk. So for the cardiac arrhythmia, there is a lot of studies. There is some studies, retrospective review that showed that there is no increase in hospitalization for arrhythmia during Ramadan. However, for the risk of stroke, here we know there is an increased risk of ischemic stroke during Ramadan with the risk of hospitalization in the risk of in intensive unit. And here we should pay attention because for stroke, the majority of studies showed that there is an increase of stroke, contrary that we have shown in coronary disease. So acute events during fasting require separate assessment for cardiac and cerebrovascular risk. So for the cardiometabolic changes during Ramadan, so as we published a few years ago about the biomarker, we can see some fluctuation of metabolic biomarkers, but it's really, we can have some increasing in glucose, triglyceride, and creatine, but the good thing is reversible after Ramadan. And we can and sometimes have a decrease of A1C, especially for person who follow the education and follow the lifestyle and have a good medication adherence. So this is the first thing. The second thing for person who do CGM, this is and with stable coronary heart disease. So in one study that was published 5 years ago or 6 years ago, the authors, they demonstrated and they found that there is a more frequent asymptomatic hypoglycemia, but without impact on cardiac complication. So and in another reviews, there are no adverse metabolic changes in patients with diabetes and cardiovascular disease so fast, provided they have adequate education and monitoring. So here to insist, if the patient is stable, if he has a good medication adherence, or good adherence to his lifestyle, a good monitoring, and he can do consultation in any time. Here, this person could do fasting of Ramadan, but we should pay attention and we should stratify the risk for this patient. So now for the medication, we know that we have a lot of patients that are treated by antiplatelet medication, especially person with already cardiovascular disease. In two studies that we published many years ago, we found that we can have some resistance to clopidogrel and to aspirin during Ramadan for diabetic patients. And here in some explanation that we found that in sometimes we have a prothrombotic state during Ramadan, especially when we are at high cardiovascular risk, and sometimes we have altered drug absorption. Sometimes there is a problem of metabolism of this medication, especially with lipid metabolism during Ramadan, especially for diabetic person. And for this reason, the altered pharmacodynamics of antiplatelet necessitate vigilance in high cardiovascular disease. Then for the medication, and we put already this in our guidelines for antihypertensive, for lipid treatment, for the other antiplatelets. So here, just we should keep the same dose of this medication, but we should adjust for the time it will be. It could be at iftar, at suhoor, but in all cases, this should be discussed with the cardiologist, the GP, and the endocrinologist. So then for the heart failure medication, patients with heart failure who are on ACE, beta blockers, or other aldosterone or mineralocorticoid antagonists may require dose reduction, but this we could not do this directly, but we should discuss with the cardiologist who prescribed this medication. And sometimes we are obliged to reduce the medication, especially the antihypertensive, especially for patients with hypotension or electrolyte disturbance due to dehydration during Ramadan. So here we can do some monitoring of blood pressure and to see if we should reduce or no the medication for hypertension. So then for summary, who is at highest risk and patient profile requiring really maximum caution? That we are talking about the patients with recent cardiovascular event less than 90 days before Ramadan, or with complex coronary disease, or with high syntax score, person with congestive heart failure with impaired renal function, uncontrolled diabetes combined with uncontrolled hypertension, and patients with history of stroke or TII. So here, these patients are at high risk of doing Ramadan fasting. So first recommendation, the assessment is very important. So the pre-Ramadan visit is mandatory. We should do this visit 6 or 8 weeks before Ramadan. And now it's time to review and to assess all the complications, the diabetes control, the hypertension, everything, and to give the advices. And sometimes we should switch some medication, reduce some medication, but this visit is mandatory for patients with diabetes and macrovascular disease. Then the risk stratification. Now we have the new IDF-DAR risk calculator that will be published in a few days in Diabetes Care. And this is, it's very important to do to quantify the risk score of this person who want to do fasting. So this, the statute of macrovascular disease alone should trigger a comprehensive risk review. And just here, and from the survey that we did 2 years ago, for example, here we compare the score risk for patients in the control group, it was about 3. And for person with cardiovascular disease, it was very high, more than 6.5. It's about 10. And a score in the past, as you know, the score more than 6, it's highest risk to do the fasting of Ramadan. Recommendation number 3 is the technology. So it's important to monitor the glycemia. If we can have CGM, is the best thing. Now we can see the tear, you can see the everything, the tear, the TBR, the tear, the coefficient of deviation and everything. And this, it's very important. This is first to see the control of diabetes, but now we know with the new CGM, we can have alarms when the person will have hypoglycemia, before the hypoglycemia, before the hyperglycemia, and will prevent the person to break his fasting, because there is really a harmful, perhaps, risk to continue to fast. Fourth thing, is very important to do education. We should take time before Ramadan to make education for our patient, especially who were at high cardiovascular risk, especially the person with complications and the person who will do fasting. But of course, even for persons who are not doing fasting, we should do education, because we know that we can have some complication due to the modification of the lifestyle during Ramadan. So especially the diabetic person who will fast, but of course the person who will not fast too. So, and then a conclusion, our conclusion is a call for caution and recall. While overall severe adverse cardiac events may not significantly increase, the macrovascular disease patient population is metabolically fragile and requires a strict safety margin. And here, the key takeaways for clinical practice: pre-Ramadan assessment is mandatory. The decision to fast may be individualized and considering the specific macrovascular disease subtype and control status, and more robust studies are urgently required to provide evidence-based guidelines for medication adjustment. Thank you for your attention. And then before finishing, we should here assist on the vigilance during Ramadan, education, monitoring. There are no negotiable. Thank you very much.